my dear colleagues and attendees. Today, really, we are going to discuss a special and hot and very important topic, which is sepsis. And today, really, a special night. We are going to enjoy and sharing a professional and experienced personnel with 4 famous and talented guest speakers. As we know, sepsis is defined simply as a dysregulated immune response to infection. Sepsis is sometimes difficult to and represent some challenge for diagnosis, and you can go through extensive biomarkers investigation and lab investigation and so on. And the main problem of sepsis really, it leads to cognitive dysfunction, psychological breakdown, and function disability. And so it is a loading problem, not only for the patient, but also for the family and for the society, and causing too much cost. When we speak about sepsis, really, we have to ask many questions. And I think this night, all our questions and all our query will be answered by our famous guest speakers. We have to ask about what is the meaning by early goal therapy, and what is the difference between early goal-directed therapy and late, and what is the optimum time, 2 hours, 1 hour, 6 hours. And as we know, every year or every 2 years or every 3, there is new definitions for sepsis to try to avoid missing acute states or missing diagnosis of septic cases. Also, we have to ask about many problems in sepsis. About antibiotic, for example, we have to start empirical antibiotic without culture or directed therapy, better and waiting the culture results. This is very important. And if we start empirical, what is the rule of steward regulation of this antibiotic after that? There are many points also which will be answered by our guest speakers, inshallah, about the role of steroids and at what time we have to use, the role of statins, the role of nutritional support and immune modulation. What is the role of vitamin C, vitamin D, and. And what is the meaning of dysregulation of immune response? This meaning hyperimmunity or low immunity or hyperinflammation and the cytokine storm, and how to avoid the role of anticoagulant and even thrombolytics in such situations. At what time we have to use it? Many questions really. Also, what is the role of CRT and the hemofiltration especially, and if it decreases the cytokine storm and improves the patient result? All these are questions, and we have to share our guest speakers and their experience, which is, I think, professional experience. And really, I am lucky today, and I am lucky this night to introduce my dear colleague, Dr. Hesham Atta from the Gazi University. He's working now as an intensive care consultant in King Abdullah Medical City in Mecca, Saudi Arabia. And I hope to sharing him and try to help me for welcoming him. Welcome, Dr. Hesham, and the mic for you.
Welcome, Dr. Ansari. Thanks for this intro. Inshallah, it is my pleasure to join this great team and great webinar regarding sepsis, and to be a presenter also in this webinar. It is an honor to me, inshallah. Today, inshallah, I will go directly to my topic, which is 1 hour approach to a septic patient. Okay. Our objective today, inshallah, to understand sepsis as a life-threatening disorder, sepsis pathophysiology, and the importance of early intervention if we discover the patient in sepsis, and our one bundle priorities and targets. Despite the best efforts and protocol-based management, sepsis is continued to be a significant healthcare issue. It carries high mortality, up to 25% of sepsis may die, 50% of patients went in septic shock. The Global Burden of Disease study in 2017 reported that sepsis occurred in up to 50 million people worldwide, ending to a death of 11 million, which represent up to 20% of the global deaths. NHIS reported 2019 that sepsis is the leading cause of death in non-cardiac ICU. So sepsis, another issue of sepsis is regarding increasing mortality, it also increasing morbidity. 40% of sepsis survivors after a prolonged ICU stay were found to have a range of physical, psychological, and cognitive complications. Up to 43% of sepsis survivors is found in one study did not return back to work for 1 year. Sepsis is also considered as a burden on resources. It costs 17 billion per year. This is a very important slide. This is important diagram and the flow chart, which we can start with a patient, healthy patient, when he develop infection. Either he will go to appropriate host response or inappropriate host response or exacerbated host response, which will end by, if appropriate response, he will end by recovery. If inappropriate response, by organ failure, sepsis, and it may go secondary infection, ICU stay, prolonged ICU stay, and chronic illness, which was persistent inflammatory immune suppression and catabolism syndrome, may later on end by recovery or long-term complication of sepsis and morbidity, or may end by this, as we discussed before, it is up to 50% may die from sepsis. So what is infection? Infection occurs when a germ enters body inducing tissue damage. If we have appropriate host response, balanced response of pro-inflammatory and anti-inflammatory mediators, infection will be controlled, tissue healing will occur, and the recovery is the final destination. Some people did not go with appropriate or balanced response of pro-inflammatory and anti-inflammatory, so it going into exacerbated and unbalanced or dysregulated host response to infection, and end by associated with organ failure. This is what's called, we have a sepsis. So sepsis by definition is related from infection, dysregulated response, organ dysfunction, and life-threatening, as we discussed, affecting morbidity, mortality, and cost issue. So as per sepsis campaign definition, sepsis is a life-threatening organ dysfunction due to dysregulated host response to infection. So why dysregulation happen? Actually, it's of unknown cause. We don't know why patients develop dysregulated response. Imbalance between the pro-inflammatory and anti-inflammatory. So, but we have high-risk patients. We have to keep on our eyes on this high-risk patient. High-risk patient, elderly people, more than 65 years. They found the age by itself. It's an independent predictor of mortality. Immune suppression, our immune compromised patient or cancer patient have tenfold increase in risk of developing sepsis. Community-acquired pneumonia causing sepsis, around 50% of community-acquired pneumonia develop sepsis and 5% develop septic shock. Previous hospitalization, it carry up to threefold increase the risk of developing sepsis for subsequent 90 days for patients, especially who are receiving antibiotic. Intensive care unit admission, also it carry risk of nosocomial infection up to 50%. Positive blood culture, bacteremia, 95% of patients develop bacteremia, develop sepsis and septic shock. And some genetic predisposition, we may found some people with genetic predisposition to develop sepsis. So second point we have to know about it, organ dysfunction. What is the definition for organ dysfunction? Organ dysfunction is defined in sepsis campaign as an increase in SOFA score by at least 2 points from the baseline. So what is SOFA score? SOFA score is a sequential organ failure assessment score. It's used only on mainly in ICU, and it used to predict mortality. It assesses severity of dysfunction for 6 organs: CNS, cardiovascular, respiratory, GI, renal, and hematological disorder. It should be calculated on admission to ICU, then every 48 hours. SOFA score now is available in Medicalc. You can go to Medicalc and put the parameter of your patient and the vital signs and the lab finding, and then you will find the SOFA score. So if we reach 2 SOFA score or more, so we have per definition organ dysfunction. And if we reach 2 or more, 2, it equal 20% mortality. If we see here, if we have a patient with a BF ratio less than 300, with creatinine raised from baseline to more than 2, liver dysfunction, and cardiovascular is hypotensive, and with thrombocytopenia, with GCS is low, it may reach mortality up to 95%. SOFA score, it is not applicable for screening, especially outside ICU. Outside ICU screening, it needs something simple, fast way to screen patient outside ICU, because most of the required data for SOFA score are not usually available at the bedside. And also SOFA score is not applicable with pregnancy. We have some physiological changes which occur with pregnancy, overlap with the criteria for sepsis. So for this two difficulties, they made for screening a very simple, very fast, what is called quick SOFA. It is the 3 simple parameters: altered conscious level, blood pressure, and respiratory rate. And if quick SOFA score 2 or more, it is per definition possibility or susceptibility of the development, the presence of sepsis. And it is used mainly outside ICU, cannot be used in ICU. But quick SOFA score has some limitation. It is low sensitivity, up to 50%. It identified patient late in the course of sepsis, and it needs a careful interpretation for defining sepsis. The physician should know if this patient already has changes in the baseline state associated to infection, and he should know also the pre-existing chronic disease. If patient already has a stroke, the sepsis conscious level from the start, his basal blood pressure around 90, so he should decide this patient already in sepsis or not in sepsis. For pregnancy, due to the overlap of the physiological parameters, there is a sepsis in obstetric score, SOS score, which makes some modification of the vital signs and the parameters related to the physiological changes. But actually, this score is still under validation, is not approved till now. Why organ dysfunction happen? If we have a patient that we know the definition of organ dysfunction, what is the mechanism of organ dysfunction for in sepsis patient? If we say the high-risk patient exposed to pathogen, it will go in cytokine storm, imbalance, increased pro-inflammatory more than the anti-inflammatory, activation of different systems. This different system complement coagulation cascade, platelet, endothelium, polymorph. I will go to the next flow chart. It will explain it more easily and more clear explanations. So if you have this regulated response, more pro-inflammatory mediators, with this activation of coagulation cascade, which make more than the fibrinolytic system, make microthrombi, affecting the capillary perfusion itself. Activation of polymorphin nucleosides, it will stimulate endothelial injury and increase permeability and the tissue, then tissue edema. Again, tissue edema, it will make more pressure and encouragement on the microcapillaries. Endothelial injury also and stimulation increase prostacyclin and nitric oxide, which is causes vasodilatation, then hypotension. Loss of the autoregulation, and autoregulation is the main concern if a patient is in shock. Autoregulation is the mechanism by which the body can divert or shift blood from non-vital organs to vital organs, brain and the heart. In sepsis, due to nitric oxide and the prostacyclin, patient and the body failed to control or to loss of its autoregulation mechanism. This myocardial depression occurs due to mediators and decreased cardiac output. Erythrocytes also, it lost its normal ability to deform, so failed to go through the microcirculation. So from this, all initial 4 parameters we found we have decreased oxygen delivery, hypotension and hyperfusion, and oxygen and the RBCs itself, it cannot go through the microcirculation. So we have a point here, decreased oxygen delivery to the cells. Even the cells, it may be affected with mitochondrial dysfunction. Even if the oxygen reaches the cell, it cannot utilize it. Failure to utilize oxygen due to mitochondrial dysfunction, which happens with this dysregulated host response. Activation of different cell this pathways and causing more injury. So by this, we have widespread cellular injury and organ dysfunction, which may end by septic shock, and which is by definition sepsis campaign, fluid refractory hypotension requiring vasopressors with tissue hyperfusion documented by rising lactate more than 2. So we have no organ system immune against complication of sepsis. No organ is protected from consequences of sepsis. So in nurse cardiovascular respiratory, we have up to 50% may develop acute encephalopathy related to sepsis, 60% cardiomyopathy, and 7% of septic patients may develop ARDS. Again, we go again to our important slide, which through it we have to know, we have to block or to break this cycle. We have to early recognize patients' infection and sepsis, and we have to go for early intervention to prevent this great complications or major complications of morbidity, mortality, and the cost. Early recognition, it should be through the awareness, community awareness of medical staff, and by screening. We have to put a system of screening to early recognition of patient and sepsis. In KMC, alhamdulillah, initiated by the help of Dr. Adil Hussein to reach a plan for sepsis alert team and screening, still under processing and hold for a while because of the corona status, and inshallah we can resume after within the coming months, inshallah. Early intervention, as per sepsis campaign, we need a team to follow and to manage. We have to go through the evidence-based guideline or evidence-based recommendation, which is our one bundle. Our one bundle, actually, it is 5 points mainly. Measuring lactate, blood culture before antibiotic, broad-spectrum antibiotic, begin IV fluid, and apply vasopressors if indicated. We'll start by the first one, which is lactate. Lactate, measure lactate and remeasure if initial lactate more than 2 millimole per liter. So this is the pathway which we end by production of lactate. If we have glucose metabolism, it may go to anaerobic pathway and end by energy production, or end by anaerobic pathway and giving us lactate. So in general, if patient will have hyperlactatemia, we have many causes of hyperlactatemia. It may be exogenous if we are using lactate as a buffer during CRRT machine, or endogenous. The endogenous come from overproductions of pyruvate, glucose, increased glycolysis, and overproduction of pyruvate. So glycolysis may be due to basal metabolic rate issue, beta-2 agonist stimulant, we are seeing epinephrine use, it's a beta-1 medication, or it may be we have another substrate for this increased pyruvate production. We have hematological malignancy, which is the commonest finding in ICU to find patients with hyperlactatemia due to underlying hematological malignancy due to overproduction of pyruvate substrate. Second, if we have a problem in pyruvate clearance, like pyruvate dehydrogenase problem, which you are seeing due to thiamine deficiency, metformin toxicity, and in some people with congenital disorders. We may have another point regarding the pyruvate clearance, which is due to mitochondrial dysfunction, due to decreased oxygen delivery, cyanide toxicity, or drugs. Commonly we're using antibiotic, which is one of the medications which may increase lactate due to its effect on mitochondrial dysfunction, oxidative phosphorylation process. And we have if we have anaerobic production of lactate, if we have liver impairment, renal impairment is a matter of clearance. So in sepsis, we see patient in sepsis, we may use epinephrine, we may use, sepsis also documented to have a thiamine deficiency, we may have a sepsis in hematological malignancy, we may have oxygen delivery decreased as discussed in pathophysiology, antibiotic use of linezolid, organ dysfunction, liver and the kidney. So this is the main causes of increased lactate during sepsis or septic shock. Lactate is a marker of tissue hypoxemia and ischemia. It does not diagnose sepsis. As I said, we have many other causes rising lactate, not related to the sepsis. but it can tell us how bad his circulation and the tissue oxygenation is there. We can make use of or get benefit from monitoring lactate in sepsis. It may identify for us early detection of what's called cryptic shock. Cryptic shock is the patient in shock while preserved blood pressure. So blood pressure is not a marker of shock. Tissue hyperfusion and hyperlactatemia or tissue hyperfusion is the marker of septic shock, what's called cryptic shock. Preserved blood pressure with tissue hyperfusion. It predicts outcome. If we have still rising lactate despite our management or rising lactate outside in the floor, it may be an indication for poor outcome and they may need ICU admission to ICU. It helps to guide therapy. If we can lactate to decrease with fluid challenges as a monitor, this is one of the indication. It may help us to decide we may go for fluid challenge more and more. Second point is a straightforward point. We need blood culture before giving antibiotic. It's not a matter, get blood culture before giving antibiotic. But I will give them some practical points. It's very important. So don't delay antibiotic to get the culture. If you have a problem in the resources, problem in the bottles availability, problem in the availability of the staff getting the culture, give the antibiotic, don't delay. Don't send blood culture from any vascular devices inserted less than 48 hours. It is unlikely to be a source of infection. Fill aerobic bottle first if you don't have enough sample, as most organisms grow mainly aerobically. In 50% of patients, the source will not be determined, which is culture negative sepsis, which can be seen in respiratory tract infection, are the commonest site to be culture negative. But urinary tract infection are the likely to be a culture positive. Other causes of culture negative: receiving antibiotic prior to admission, insufficient or incomplete diagnostic workup, unusual organism, or this situation is not related to non-infectious cause. We go with culture negative. Give broad spectrum antibiotic and a delay of antibiotic more than 1 hour, it will increase mortality. Appropriate empiric antibiotic should be based on or guided by the possible source, their immune compromised patient, local antibiogram, risk factor for resistant organism. For the possible sources, they found pneumonia represent 50% of the cases went on sepsis and septic shock. Urinary tract 20%. The least causes of sepsis or septic shock: endocarditis, device-related meningitis, and others, which represent totally 5%. We have to know also inappropriate antibiotic use or improper selection, it will increase mortality by 34%. The best way, of course, to know the antibiotic is to know the organism by the culture and sensitivity and to know the MIC, but it needs time. De-escalation and the early cessation of antibiotic should be discussed daily. Antibiotic 7 to 10 days course of antibiotic is appropriate for most infection, but we may need longer course of treatment if we cannot control source in immune compromised patient in a special situation like Staph aureus bacteremia, endocarditis, and fungal infection. The fourth point is to start to give fluid. As per sepsis guideline, they recommend to infusion of intravenous fluid 30 ml per kg starting within the first 1 hour and completed within the first 3 hours of presentation. But does it applicable for all patients? For all patients, we have to give the 30 ml per kg. What about renal failure patient? What about heart failure patient? What about ARDS patient on mechanical ventilation and conservative management? So to know we have to go for all patients or not, we have to know some facts there. The only reason to give IV fluid is to improve our cardiac output. If we have patient, if I give fluid to a patient, what I waiting for the result? To increase cardiac output. If cardiac output not increasing, so the patient will not get benefit. Not all shock patients will get benefit from giving fluids. Approximately 50% of fluid bursts fail to improve cardiac output. Giving unnecessary fluid exposes the patient to a volume overload, which worsens patient outcome. A lot of studies supporting the concept of conservative fluid resuscitation and document the worsening in the outcome and volume overload, like FACT trial, FAST trial, FEAST trial, many trials going with conservative, which is improving the outcome and tissue edema and renal replacement therapy, positive balance and giving more fluid and volume overload, it will end by increased mortality. So why not all patients will get benefit from giving fluids? So according to Frank Starling principle, as the preload increase, the stroke volume increase up to limit. This is the curve. In preload increase, stroke volume increase. Straight part. In normal physiological condition, both ventricles operate in the ascending portion of the Frank Starling curve. Once the left ventricle is functioning near the flat part of the Frank Starling curve, the fluid loading has little effect on the stroke volume. So here, so we need our patient to be in this flat part. So we have to find the fluid responder, which benefit from fluid resuscitation. By giving, when I give a fluid, he should have increase in the stroke volume and the cardiac output, and with reasonable rise in the preload. If we reach here, you will see here we have large increase in cardiac output in this area, but here we have a small increase in cardiac output, but large increase in the extravascular lung water, which carry risk of volume overload, more worsening of the hemodynamics, more volume overload, and worsening outcome. So ascending portion of the Starling curve is our target to find our patient here. How to determine fluid tolerance and the fluid responders? We need two things. We need 2 points to reach, must be met. We have to create a change in preload, and we have to assess this change in the preload and the effect on the cardiac output and stroke volume. The change in the preload is divided mainly in 3 points. A change in preload with heart-lung interaction, change in preload with fluid challenge, change in preload by fluid redistribution. So a change in preload, heart-lung interaction, as we know, they make use of the change in the interstitial pressure during inspiration and expiration. During that time, during inspiration, finally we have decreased right ventricular stroke volume, but we have increased left ventricular stroke volume and increased blood pressure. During expiration, the reverse is here. We have decreased the left ventricular stroke volume. So blood pressure increased during inspiration, and pulse pressure increased during inspiration, and decreased during expiration. Through non-invasive cardiac output monitoring, we can check these variations: pulse pressure variation, stroke volume variation, systolic pressure variation, or VTI by echo, or vena cava indices. I will not go in details through these indices because it needs by itself another lecture. But we have to know we have a way to assess or to make a change in the preload by heart-lung interaction to assess fluid response through these modalities. But these modalities actually in ICU, we may face a difficulty to be applied in ICU. It needs all to be with sinus rhythm, normal volume cycled ventilation, tidal volume at least 8 ml per kg, heart rate, respiratory rate ratio, no ventilator patient ventilator dysynchrony, normal chest compliance, normal intra-abdominal pressure, and normal pulmonary compliance. Another way of fluid challenge assessment or change in preload by fluid challenge. Fluid challenge used mainly to stop fluid. As we know, we decide we go with conservative management of fluid. The only patient will get fluid is the fluid responders to avoid fluid overload, which increases mortality. So the target of fluid challenge to test this patient already has a good volume, I will stop giving fluid. The disadvantages of fluid challenge is that I give already fluid, I cannot remove it again. If patient already volume overload and I give fluid challenge, so he receives the fluid, becomes more overloaded. So to do fluid challenge, it requires also 3 points. We need to give volume within a time. We need to assess response, which should be through monitors. We have to avoid false interpretations. For volume within a time, we have to give volume crystalloid for ml per kg, or we may go with colloid, which is called mini fluid challenge, 100 ml per stat. Time should be within 10 to 15 minutes. Rapid administrations to avoid, because if you go slow administration of this fluid challenge, redistribution of this fluid, and it lost its effect as a fluid challenge, as a fluid bolus to the patient. We have to assess the response through increase in MAP, decrease in heart rate, clinically, the increase in cardiac output and or stroke volume by 10%, or echo assessment, reasonable raise in the cardiac filling pressure. And we have to avoid false interpretation. Any stimulation of the patient, any change of the regimen of medication currently the patient is on, it may affect the result. So don't touch the patient, don't stimulate him, don't increase or add a new medication like vasopressor dose, don't increase the dose, don't start vasopressors and do fluid challenge. It may mislead you as an interpretation of fluid challenge. The third and last one to change in the preload is by fluid redistribution. Fluid redistribution through passive leg raise, lifting the leg passively from horizontal position, inducing a gravitational transfer of around 300 ml from the lower limbs towards the intrathoracic pressure, compartment. Passive leg raise is considered auto-transfusion. It is reversible. It is different from fluid challenge. It is reversible. If I don't found my patient fluid responder, so if I just reversing its effect, once the leg are tilted down again, so its effect is resolved and this effect is subside. So it's considered auto-transfusion and reversible. The FEAR and the Jane 2015 put 5 rules to do passive leg raise in a proper way. First, to start from the semi-recumbent and not from the supine position. Put the patient semi-recumbent first step. Must be assessed by direct measurement of the cardiac output and not by the simple measurement of the blood pressure. Passive leg raise, it will take time only 1 minute. It will vanish within 1 minute. So we need real-time monitoring of cardiac output. So echo, pulse contour analysis, esophageal Doppler, change in the exhaled end-tidal carbon dioxide. It may guide real-time monitoring of the cardiac output. Cardiac output must be measured during and after passive leg raise in order to check that it returns to its baseline. Again, like a fluid challenge, avoid false interpretation. Bronchial secretion, suction, stimulation of the patient, touching the patient by your hand and performing raising passive leg raise by your hand, it may stimulate the patient. It may falsely giving impression of increased cardiac output, while it is due to your stimulation and increased catecholamine by your stimulation. We have to know also fluid resuscitation in general. We are testing fluid responsiveness mainly. It makes sense only in circulatory failure. Keep in mind that none of these tests are 100% sensitive or specific. You have to keep your eyes on fluid balance. Under or over hydration, it may harm the patient. Dynamic blood pressure monitoring, tissue hyperfusion, lactate clearance, and the most important urine output also can be used as a monitor. With any new vital changes, please reassess your patient again. This is a very nice review, 2018, the principle of fluid management and stewardship in septic shock. It is time to consider 4 Ds and 4 phases of fluid therapy. It's a very nice review. It deals with the fluid like a drug. We need 4 Ds like a drug. What is the type of the drug we will use, duration, dosing, and de-escalation. We need also to manage fluid resuscitation as an ROSE concept. Start by resuscitation, optimization, stabilization, and evacuation. De-escalation and evacuation means all of them we are going to also conservative. We have to limit volume overload. They found a patient positive balance by day 3 in ICU, it increased mortality. So also this is the view.
Can you just make more quicker? Just coming to a conclusion, please.
Sorry.
Yeah,
Okay.
over time a bit.
Just give me 3 minutes only.
Okay, thank you.
So, what type of fluid? Fluid mainly by evidence-based and the study found ringer like crystalloid like colloid. But in subgroup analysis or meta-analysis, we found colloid is the best. But due to availability and the low and the higher cost, they are concerning and recommending crystalloid. This is a nice study also, SMART trial 2018. They mentioned we have 9 reasons to stop using normal saline and to go for use of ringer lactate. The 8 reason, the first 8 reason due to the harm effect of normal saline. The reason number 9, because it is a better option, we have ringer lactate is more important. Currently, we have two running studies, two big studies, basics study, which will finish in October 2020, and it will be expected to be discussed in next meeting 2021 in critical care meeting, inshallah. It is done in Brazil. In Australia, another study, the same, lasmalite versus normal saline, it will end by March 2021, and we're waiting the result. Finally, is the appropriate use of antibiotic, or you're applying vasopressors if hypotension during or after. If a patient presented initially by hypotension, it carry twofold increased mortality. Our target management to reach a MAB is to restore organ function. We don't have target MAB is our management is not the MAB, the target. We need organ function. We need organ perfusion. So initially we need a MAB. This MAB should increase organ perfusion pressure or reach the target organ perfusion pressure, which will later on improve organ function. A target MAB per sepsis campaign more than or equal 65 millimeter mercury. But we may accept lower MAB, especially in patients we have cardiomyopathy, low ejection fraction, low contractility. We may accept MAB. We may accept a higher MAB in patients with hypertensive. It was increased the ICB, with increased the intra-abdominal pressure, with increased the CVB. All this one we are dealing with increased the organ perfusion. So our target is the organ perfusion pressure, not a MAB. Our target is the organ function, not a MAB. First, of course, the recent study 2020 recommend early use of vasopressor. It will improve outcome and decrease the burden of using volume overload. Standard vasopressin is an aid to decrease the requirement of levofed, but alone as a monotherapy failed to show any improvement. Dopamine it is not recommended, but may be used in significant bradycardia. Angiotensin 2 is approved, but still we have limited study for using as an alternative as a vasopressors. Our 1 hour bundle practice, we face a problem regarding start, which 1 hour, from where we should starting time, from sepsis onset or from ER entrance, from diagnosis, from antibiotic order. The antibiotic within 1 hour. Till now in our hospital, we fail to give antibiotic within 1 hour from diagnosis. System problem, entering, approving, culture, everything. We fail to give within 1 hour. And this is a study 2019, they said they found no difference between giving antibiotic within 3 hours or within 1 hour. Lastly, lactate availability as a monitoring in all hospitals is not available all the time. I think our one bundle should be reviewed, maybe return back to 3 hour bundle may be more applicable. And take home message, despite best effort of protocol-based management, sepsis continue to be a significant healthcare issue. Early recognition and then intervention save lives. Till now, our one bundle is a recommended initial protocol of management. Delay or appropriate antibiotic increase mortality. Not all shock patients will get benefit from giving fluid. You have to find the fluid responder, and resuscitation target is to achieve an adequate MAB and maintain organ perfusion pressure, which help restoration of organ function. Thanks a lot, and thanks for time.
Thank you, Dr. Hesham. Nice and attractive lecture, really, and updating and summarized. Thank you. We have some questions here, and I think routine questions in such cases of sepsis. What is the fluid you prefer, type of fluid you prefer, and if you give lactate, renal lactate, you don't afraid from increasing lactate level?
Actually, first طبعا full as per recommendation, the guideline and the study and this we said the smartest trial, it recommend mainly renal lactate. Normal saline carry a lot of mortality, a lot of drawbacks, hypercholemic metabolic acidosis, renal impairment, requiring renal dialysis. So the first choice currently per evidence is the renal lactate. Renal lactate does not contain lactate. It's bicarb. It is mainly metabolized in the liver and in the bicarb, and even it may improve the acid-base disorders of a patient with septic shock.
Right. About biomarkers and procalcitonin and lactate level, you depend on these biomarkers for giving antibiotic?
Yes, procalcitonin is now 1 point. We can cut point to 0.5. We can use it less than 0.5. It may not be considered as a bacterial infection, but we may have another. Procalcitonin mainly used for bacterial infection. Cut point to 0.5, less than 0.5, we not consider bacterial infection. More than we may consider adding a starting antibiotic. And also it may be used for monitoring and follow up. If decreased by 50 to 80% from the baseline after initiation of antibiotic, it may give us a clue that we are going in the right way. And even we may use it as to de-escalate antibiotic use also.
Another nice question.
For lactate, we have concern regarding lactate. We have many causes of lactate. Lactate is may be due to tissue hyperfusion. It may be you have another cause. We have to be clear with dealing with lactate as a source of hyperfusion. Maybe we have another causes, decreased the clearance, increased production. So we have to think for lactate first.
Yes, differentiation between dextro and levulactate, of course. About another question she asked about the leg raising. It is essential or mandatory to be automatic by bed red, or you suppose you have no automatic bed. You can raise manual, but you are afraid from, as you told,
simulation.
Explained from force interpretation. Yes.
Yes. So as the recommendation should be by automatic by the bed to avoid stimulation. If we have patient already deeply sedated and good analgesia, muscle relaxant, and you have a monitor of level of sedation like this monitor while he's muscle relaxant, you may use it by your hand if you don't have availability of the automatic bed.
About CRT and anti-inflammatory in cases of excessive pro-inflammatory state, you prefer to give as in cases of cytokine storm and so on? This is another question.
You mean CRT or?
CRT, yes, I think I asked about CRT and especially hemofiltration in such situations of severe sepsis.
Wallah, till now I don't have an evidence to use it and to remove inflammatory markers, but I don't have actually an evidence.
If you allow me, really from our experience in ICU, it is very good and essential, especially in cases of severe inflammatory state. And even in other situations like heart failure and so on, it removes some of the cytokines and decreases the degree of sepsis, especially if you use continuous hemodialysis filtration. Sometimes use it for 2 days, 3 days, or even 1 week to tell the patient the hemodynamic state improves. Nice lecture, Dr. Hesham, and thanks for you and thanks for this nice presentation. And really very nice and very good and highly attractive. Thank you.
Thank you.